Hi, thanks for joining us. I'm Trish, the STARS coordinator at Cardinal Glennon, and I have Morgan Baldwin with us today, our nurse practitioner from our surgery department, here to help us talk about G-tubes in the pediatric population. If any of you have been dealing with any of our STARS patients, you're probably aware that the majority of them have a G-tube. So we're going to talk about what you need to know about that to care for them in the field. So our STARS patients often have G-tubes, either to facilitate feeding and medication administration or just for supplements in general. We have several who don't eat at all because they can't and they have aspiration issues, or some have oral aversions and for one reason or another, they need access to their belly. So we're going to talk about some important information that you need to know about G-tubes. During this presentation, we're going to talk about different types. Can EMS actually utilize a G-tube? Will it be of any use to us as pre-hospital providers? And what do we do if it falls out? So the most common that you'll see with our kids is the Mickey button. It's low profile. It's a very simple tube that enters into the stomach, and it's held in place by an inflated balloon. These balloons are inflated with sterile water, not saline, not air, and it has an attachment that we call the key or extension tubing. And we're going to go ahead and look at a video of how to attach that on the next slide.
Walk through a basic insertion of a gastrostomy tube. I got everything prepped. Normal amount of volume for the balloon is between 3 and 5 mils. Before I insert it, I always just double check, assess the balloon for patency, make sure there's no little micro tears or leaks. All the water comes out of the balloon. Again, I don't know if you can see this from the video, but the shaft of the button is a little bit smaller than the balloon, the diameter of the balloon. So when we insert it, we kind of have to overcome that size of the balloon first. So we've checked our balloon, we've got our syringe hooked up, a little water-soluble lubricant on the tip of it. Baby's being nice and still for me. I'm right-handed. It's just a gentle, firm pressure, and you kind of feel it slip past the fascia. I'm holding it in place, and then you blow up the balloon. It's a negative pressure balloon, so you got to keep your thumb on the plunger and just disconnect, okay? The best way to know how to assess that you're in the right spot is aspiration of gastric contents. So we have a Luer locking system, black line, lines up to black line, gentle pressure and twist. And then you can hook up a Toomey syringe and hopefully aspirate some gastric content back. Okay. I think that's it for...
So this is another type of a gastrostomy tube. A lot of times you'll see this as the primary gastrostomy tube, what the surgeon initially places from the operating room. Functions exactly the same. There is that retention ring that is movable. It just allows for postoperative swelling. Typically, if you see a patient with a gastrostomy tube, it's either a fresh post-op, so less than 4 to 6 weeks postoperatively, or they may be on continuous feeds, which is also a better option for them.
So there's another type of tube that you might see with some of your kids, and it can be confusing because it is also low profile, but this is actually a GJ tube, a gastro-jejunostomy tube. So these are for some of our kids who have very poor stomach function, slow motility. They just have that chronic vomiting and severe GERD that we just can't feed them in their belly directly anymore. So these are for slow feeds that go primarily directly into the jejunum bypassing the stomach. And this one has 2 access ports, one that goes into the stomach and one to the jejunum, which you can see pictured below. We can also demonstrate that in a video as well. So what you need to know as pre-hospital providers and in the emergency room too is that this is something that we can't replace. This kid's going to have to go back to the surgical team if this becomes dislodged or becomes clogged. Other things you need to know is that we don't do any sort of boluses into the J port. but we can still, if we have to access that for any reason, which we're going to talk about later too, you're going to be wanting to use that G port going into the stomach. If the J port becomes clogged and you're not able to flush it for any reason, the child still needs to come into the hospital because there's a potential that might need to be replaced. Morgan, do you have anything you want to add about GJ tubes that I didn't cover?
The biggest reason why they get clogged is not flushing in between medications. So if you can kind of get a better handle on which medications maybe the parent gave and how much formula they were being given at that time, that might help us determine how we're going to potentially unclog that J port.
Here is a GJ tube, so it's a gastric jejunal tube. So most kids are fed continuously with a jejunal port, which is right up top here, if I can show you there. These are specially measured and placed in interventional radiology, unique to this patient, the length and the depth of it. They will get clogged, and they will get dislodged as well. One thing to mention on the GJ is, here's your balloon port, and that's where your water is going to be in the balloon port holding that in place there. And then here's your gastric port. If you ever needed to decompress the belly, put that to gravity, it works exactly the same way. Again, it's a little bit of an awkward angle, but luer locking, black line, lines up to black line, gentle pressure, and a twist. And there you should get gastric contents. Or if the child's having emesis or a distended abdomen, you could again just leave that G port, the gastric port, to gravity as well. GJ tubes do become accidentally dislodged. And if that happens, sometimes they're partially dislodged. So here's the balloon on the G port. Sometimes they become partially dislodged, and it might kind of be hanging out looking like this, or they can come all the way out. If it's out and like this, I would say, again, dry gauze and tape and bring them to their specialty hospital. When they come out, they're pretty long. It's down into the jejunum, so it's a pretty big tube. Again, not something that can be replaced in the field. They'd have to come to their local hospital for that.
Can G tubes be of any use to EMS providers? Early in my career, I didn't really consider that to be anything that would ever help me as a paramedic in the field, but there are some reasons that we might want to utilize them and access them.
Venting the G tube. This is something that's actually pretty important, and you wouldn't really know out in the field if this patient had a Nissen fundoplication where their stomach is a bit smaller, but any kid that is sick is probably going to need to have their G tube vented. Their stomach is probably pretty distended with air and or gastric contents. So simply hooking up that key extension set and a TUMI syringe, an empty TUMI syringe, is always a good idea. This will allow excess air to be vented out, and you're also going to decompress the abdomen at that time. Some kids are actually on a venting schedule. It's almost like a burp before and after feedings. One thing that we do say is, if the child's having emesis or you've hooked them up and their G tube is to drainage, don't ever place it to suction. We really don't want suction pulling on that gastrostomy tract, because you can actually prolapse the stomach with a suction applied to the G tube.
Does it make a difference, Morgan, if you do attach like that 60 cc syringe like you see in the picture, or if you drop it to gravity and just wrap a diaper around it? Is there any benefit to either, or reason you would do one over the other?
No, not really. If you just fed them, if parent states that they just fed the baby, but their belly is distended and they're a little bit firm, maybe opening up the syringe like that will allow for a gaseous burp, if you will. But yet the child can still retain their feeding. If they're sick and they're having emesis, they probably just need it down into a gravity in a dry diaper, because we need to decompress the belly.
Should EMS be alarmed if they just get tube feeds pouring out of it or bile or anything that looks awful? Is there a reason they should stop, or should they just let that empty if there's pressure?
So I think if it's bilious output from the G tube, just leave it to gravity for sure, because obviously that a bilious emesis or drainage from a G tube site is a sign of an obstruction. So we want to try to get the bad stuff out, if you will. And it depends on what the report is from the care provider. If they had just received a feeding and you open up a syringe and 200 mils come back, well then you would kind of expect that because they just received a feeding.
Good to know. So there are times when we aren't able to get IV access on our kids, and especially when we're talking about our STARS population, they can be especially difficult to gain access on. One reason, the most common reason that we see a G tube being accessed in the field, or that we ask for EMS to access it for medications, would be for the administration of glucose. That is considered actually less invasive and safer to administer glucose via the G tube than attempting IV access and risking infiltrating it within the IV, or doing the more invasive route of getting an IO to treat them. If you have Pedialyte available, and the situation calls for it and is appropriate, you can do rehydration with low volumes continuous feeds, and I'm going to let Morgan expand on that a little bit. If we are flushing these, we need to remember that we're flushing with water, not saline. And there's some notes on here that for infants and toddlers, 5 to 10 mils of water can be used to assess patency prior to, and I'm going to ask Morgan too to confirm if that's with flushes as well. And then for children, the 10 to 30 mils to assess patency, to make sure that you've got a nice clear tube before you start. Can you tell us a little bit more about that, Morgan?
Yeah, so the G tube is our safety net for these complex children that can get dehydrated pretty quickly. So we will oftentimes give Pedialyte. Again, it would depend on the patient and what their typical feeding regimen would be. If they're always on continuous feeds, then we would definitely start with a low volume, maybe even half the volume of their normal feed. But in Pedialyte, just to get them some hydration and make sure that they are able to maintain their blood sugar. Infants and toddlers, obviously, you want to start a little bit lower with how much you're going to push in there.
So Morgan, is tap water okay to use for a flush, or does it have to be sterile water?
Yeah, at home in the community, we definitely use tap water. I mean, parents often mix formula with tap water. Tap water is absolutely safe to use. Also, when checking the button, here in the hospital, we use sterile water to check the balloon, but at home, parents will use tap water or bottled water for that as well.
Now, when they're administering, fluid or glucose, how important is it not to rapidly flush? Should they just let this drip in by gravity, or how do you suggest they actually infuse?
Again, probably patient dependent. If they have a kangaroo feeding pump at home, I would definitely say slower is always better. When you guys are seeing these patients, they're sick, they're unwell. And what do? When we don't feel well, we stop eating. We feel kind of crummy, our tummies are upset. So these babies and these young kids at home aren't feeling well. And if you think about, rapidly pushing 6 or 8 ounces of Pedialyte or formula in a G tube, what's that going to do? It's going to expand their belly and probably cause emesis and more abdominal distension and discomfort. So I kind of say slower is better. If you have a pump available for you, I would go at a slower rate, maybe half of what their normal feeding volume would be. It's just a little gentler because we know they're sick or not feeling well at that time.
Many medications that can be administered via the G tube are supplied in liquid form, but children can also take their pill form medications via the G tube. They just have to be crushed up, as you're seeing in this video. A lot of times parents will have different glasses, spoons, mortar and pestle, whatever they use to break up the medications. The key thing is to make sure that they're crushed small, otherwise they'll get stuck in the G tube and clog it up. You can see that this parent is just adding some regular water. Some parents use tap water, others will use Pedialyte to administer the medication. It helps to use warm water if you're trying to dissolve the medication. Then just pulling it up into a syringe. Alright, so all the medication is captured. And then we're just going to prime the Mickey line here. You could administer air into the stomach for some of the bigger kids, but even then it's not ideal. It's just not best practice to introduce a bunch of air into the stomach. As you could guess, that'll probably make it irritable. Now we just connect the Mickey system, as we've seen in the other videos. And we're just going to go ahead and administer the syringe with the medication through the line that we've already primed. Alright, closes off the line. And then now we just need to administer a flush of regular water just to push the medication that's still in the tubing into the stomach. You can see kind of a nice slow rate there. Then we clamp off the line and remove the Mickey.
Oh no, what happens when that G-tube pops out? I feel like I've run this call more than I should, and some of you may have as well. We're going to let Morgan talk about when we shouldn't touch it, and the highlighted part, but then we're all going to also talk about why maybe we should take action and help them out, and maybe they can even stay home.
So yeah, it's a thing and it happens. And I tell parents, you know, when children get discharged from the hospital, you know, it probably will get dislodged, hopefully not within that first 4 to 6 weeks, but it does happen. The biggest thing, if it's a fresh gastrostomy tube, meaning they haven't come back to clinic or seen me or the surgeon and had their primary gastrostomy tube changed, they need to come back to Cardinal Glennon or their local hospital, their pediatric facility, to have a gastrostomy tube study. If it comes out and you are called to the scene, we would say put a Foley catheter or a red rubber catheter in the gastrostomy tube track. We don't want you to blow up the balloon of the Foley. Put a tube in, a Foley or a red rubber, like we said, and tape it down, and then come to your child's designated facility. At that time, we would want to put a new gastrostomy tube or a button in, and then do a contrast x-ray just to make sure that the tract is well established and healed, and there's no extravasation of contrast into the abdominal cavity.
So if EMS comes and this is a child who has a well-established G-tube that they've had for over 6 months, a year, etc., and mom and dad need help because they don't have replacement there, or they have, well, they'd have to have replacement for us to put it in. They don't have a syringe, we'll say, to deflate the balloon, or the child's maybe at school or with a caregiver who isn't comfortable with replacing it, and they've called 911 for help. Can you walk us through the steps of how we can replace it, and is it safe to replace it?
Yeah, absolutely. So if it's a quote simple dislodgement, which again, it does happen, kids move, they pull things. The biggest time that gastrostomy tubes are at risk of getting dislodged is when they're connected to the feeding. So we always say disconnect that extension tubing if they're not being fed, because that's just one more thing to get pulled or accidentally tugged. So if it's a well-established tract, they've had it for, you know, more than that 6 or 8 weeks, and we've done their primary change, we would just say cleanse the skin, warm water, warm soapy water, get any gastric contents, you know, away from that abdominal skin. You would check the water in the balloon. If you have the button that came out, if you have the gastrostomy tube or the button that had came out, before you put it back in the patient, check the balloon. So fill the balloon up with 3 to 5 mils of water just to assess patency of the balloon, make sure that there's no little micro tear or leak in that balloon. And if it looks okay, lubricate it with a little water-soluble lubricant and put it in the tract. You do have, you know, a couple hours probably before that gastrostomy tract starts to close. So you will have parents who say they put the baby to bed, put the big kid to bed, woke up in the morning and everything was soaking wet with formula. At some point in the night, the gastrostomy tube or button became dislodged. Those are tricky because we don't really know how long it had been out, and you might have difficulty. If it doesn't go in fairly quickly, it's going to probably mean you need to come over to your facility, their child's designated pediatric hospital, and that gastrostomy tract might need to be dilated. But if you're able to get the button in, like I said, you've checked the water, make sure the balloon is still patent, just gently, a little bit of pressure, you'll feel it slip kind of past the fascia. It sounds almost like a little pop. It'll slide past, and then just fill your balloon up. Again, usually around 5 mils of water. The best way to know that you're in the stomach is when you attach your extension tubing and you can aspirate gastric contents.
So so you said that you might feel a little bit of a pop. I just want to clarify for everybody how much pressure it usually takes to slide that back in if, this is a common, just,
It shouldn't be much.
Okay.
You'll feel it. The caliber of the balloon is just slightly larger than the actual shaft of the button, and you can see that when you take it out. And maybe in one of these videos we can kind of show you the difference in the size. So the gastrostomy tract has to accommodate that little slightly extra size of the balloon. So it's going to slip down into the tract. If you think of it like an earring, it slips down, and then you blow up the balloon, and the balloon is like your earring back.
Excellent. And so for assessing placement, you said you can aspirate for gastric contents. What if the child's not really showing pain, you can flush it, but you don't get gastric contents back? Is that common?
Yeah, sometimes you won't. And it also depends on, honestly, how much of a mess you've made. So if the stomach is empty and you don't get any gastric content back because everything that was in the stomach just came out, because the tube became dislodged, that's not uncommon. Most of the time you will be able to get some small amount of either, frothy, clear, or yellowish gastric content back. But it's not uncommon to not get much. That's a good point.
Have you opened yours at home?
No.
So it comes with your 1.5. I always check. At home you can use tap water or bottled water, but I always check the balloon before I put it in, just to make sure that it's patent. They can come out of the box and be not good. So for him, because this is a little longer, it's probably going to need a little bit more water.
Right.
So,
because I know before we said 5, right?
Yep.
Or 3 to 5.
So I just check and just make sure.
Okay.
Sorry. That there's no micro tear or anything that came out of the box.
Okay.
And then we have an empty syringe to take this one out. When's the last time he ate?
8:30, and he finished about 9:15.
So his tummy should be empty. So to take it out, again, you hook up your syringe, take the water out of the balloon. I'm right-handed, so I always stabilize with my left hand, and then button comes right out. Sorry, I was afraid that would happen.
Mom's here.
Oh, buddy bear, hang on.
Mom's here.
We got our new tube ready.
It's okay. Try it out, babe. Try it out.
Sorry, handsome. Again, just kind of wait for that cry. Just slides right in. You can feel it kind of pop past the fascia. It's a negative pressure system, so the syringe will pop off, so you keep your thumb on the syringe and then just disconnect. Okay. If his tummy were empty, to verify placement, you would, same thing, you line up the black line, lines up to your black line, and then we should see stomach contents, which we do. See, that's just, I always verify that it went in the right spot.
So Morgan, can you show us what we would do if the Mickey buttons come out and we just can't get it to go back in, or what you have is damaged and you can't reuse it?
Sure, absolutely. So usually a red rubber catheter, just because it's soft and a little more pliable, or a Foley catheter, or even a Repogel would be okay. Probably a 10 or a 12 French. You know, if that gastrostomy stoma site is starting to heal and starting to close up, you need to go a little bit smaller with your site. And really, it's just you want to insert the red rubber again or the Foley into the tract and tape it down. You just need something in the tract to get you to your local facility or the child's pediatric facility. Just taping it down. Now, if you're oozing, gastric content, I say just a dry gauze and maybe, another piece of tape there, just to prevent a mess all over the child. I don't like anything occlusive, no tegaderms or specialty bandages or anything like that, just because it's going to irritate the skin and really not necessary. So dry gauze and a piece of tape.
So in the ambulances, they typically don't carry a Foley catheter like they would in the emergency room. Would a tube like a French suction catheter or a Salem be something they could use of a smaller size?
Sure. If that hole is super, super tight and hard to get in, you might only be able to get in a 10 French suction catheter, and that's absolutely fine. You really just want something in the tract and taped down, with a piece of gauze and tape to get you to your facility, so we can dilate the tract or get an X-ray and see if we can get a new tube in.
So as far as depth, would you just measure against the Mickey button that you have?
Yeah, that's definitely reasonable. It's not too far if you have access to it. If the care provider has it, you're just going to go in. What is that? Maybe a couple inches on this. This is a 14.1.5. So in the infants and toddlers, this is a very common size. Now an older patient might be up at a 2.0 or a 3 or 3.5. But this is about how far you would want to go in. And you'll feel a little bit of resistance. You should be able to feel it slide in and stop. A couple inches, not too far. Good to know. Mm-hmm.
Just some important notes that we want to close with, and we may add some other comments as well, is that while these dislodged tubes aren't a life threat, the stoma often starts to heal itself, meaning close, sometimes within as early as an hour to 2 hours. And it's important that we get these tubes replaced in a timely manner. We don't want to be forcing a tube back into the stoma if we're attempting to replace in the field. So it does take some amount of pressure, as stated before, but if it really takes any significant amount of push or force, or what about the child showing signs of pain? Morgan, is that something, do they usually show pain or?
They're usually maybe a little fussy, maybe a little irritable, but it shouldn't, replacing a gastrostomy tube on a patient who has a well-established tract shouldn't necessarily be painful for the patient.
Okay. And then if you aren't able to replace that tube, we need to get that patient to his or her specialty hospital. It may be frustrating if it doesn't seem like a life threat and you don't know if this warrants an ambulance or not. But if mom and dad or caregiver who's at the home doesn't have transportation, please be that child's transportation so we can avoid the child having a delay in feeds and medications, or potentially having to go back to surgery, which would be the worst. So it is a case where the child does need to get to the hospital in a timely manner. And just also keep in mind that these community hospitals really often do not have the necessary supplies to care for our kids. In fact, we've had several issues where our children have gone to a closer hospital to get assistance, and they don't even have the attachments that they need to feed the child. So it is really important that that child comes to his or her hospital so they have the right sizes and everything they need to care for that child in particular. On another note, if you do transport, please bring all of their supplies from home with you. That's really important. They often have the sizes and everything ready there, but it is important that you have those with you at all times. All right. We want to thank Morgan for coming with us to be our expert in teaching about G-tubes today.
Thanks for having me.